Okay, everyone, we're going to talk about medication overuse headache, or what some people commonly know it as rebound headache, but the physicians and the healthcare practitioners, we call it medication overuse headache. It is a secondary headache disorder. So we know the primary headache disorders are common, like migraines and tension type headaches. Secondary headache disorders are like those with a concussion, post-traumatic headaches, people who've had a traumatic brain injury, or even a brain tumor, and then they get a headache. So that means it's secondary. So medication overuse headache, we classify it as a secondary headache disorder. It is defined as having 15 or more headache days per month for over 3 months. So it fits in that chronic headache disorders, just like chronic migraines and chronic tension type headaches, and usually in someone who already has a pre-existing headache disorder, and it's usually caused by overusing acute medications. Now, I know in the literature, when we look at a lot of the narrative reviews that have been done on medication overuse headaches, which there isn't a ton of randomized controlled trials or a lot of research studies understanding the pathophysiology of why medication overuse headache occurs, it typically is caused by overusing the over-the-counter medications, opioids or triptans. And we see this a lot in practice. I would say it's much more than 1 to 2%. According to the literature, it's 1 to 2% in the patient population, but it is much more in my practice. It's probably a majority of patients that I see in my practice. And so 2% of the general population it affects, and then up to 50% of patients in headache centers. So we're thinking about acute medications that are abortive medications. So these are the medications that try and get rid of your headache in the moment. These are not medications that are preventing your migraine or the headache. So when someone takes triptans, ergotamines, opioids, barbiturates, even the combined analgesics with caffeine, for example, if they're used more than 10 days or 10 or more days per month for at least 3 months, but sometimes it varies between individuals, this can actually cause a medication overuse headache. So that's only 10 days per month. And some people are finding that this can happen even 8 days or less per month. So I think there might be some variability, maybe some differences in pain connectivity and genetics. But NSAIDs and acetaminophen, so thinking ibuprofen, aspirin, etc., and acetaminophen, if these are used 15 or more days per month, can cause a medication overuse headache. So I have a lot of patients and families who were told for good reason to go ahead and take their ibuprofen or acetaminophen and to help treat their headache. Now, oftentimes they don't go back to the practitioner or physician, and so then they'll continue taking it. So I have several patients who have been taking ibuprofen and or acetaminophen, or they'll alternate it, for up to 12 years. I've had several patients come in with that, where they've done this every day and nothing helps their headache. Well, it doesn't help their headache anymore because they actually now have a chronic daily medication overuse headache due to taking these medications. And so this is why I'm trying to get this video out, because we need to address this, especially when we're educating our patients about medications to abort their headaches. Always remembering to discuss, do not take more than 8 to 15 times a month, depending upon what class it is. So, as I mentioned, there hasn't been a ton of studies on what's going on pathophysiologically, but there has been some imaging studies that do show that there are some gray matter changes, some brain volume changes, especially in the midbrain and the thalamus. So that's where the thalamus communicates to the brain, to the somatosensory cortex, where the brain is happening and is that pain receptor, as well as the orbitofrontal cortex. So there are some alterations in this pain connectivity and dopamine circuits, which are kind of along those addiction and motivation circuits, and it impairs the pain modulation, especially in the periaqueductal gray and the thalamus and the frontal lobes. So these changes, though, are definitely reversed when going off these medications, these analgesic medications. The reason why this matters so much clinically is because it is very difficult to treat, especially when they're not treated right away. So I have seen patients who have been doing this for 12 years where they're taking these meds sometimes daily or just more than 15 times a month and developing a chronic daily headache without taking preventives. So then they get stuck in a pattern, in a loop, where they're actually dependent upon these meds. So it develops into chronic pain. Now, a lot of people wonder if you don't have migraines and headaches. Say you're taking ibuprofen or acetaminophen for knee pain, for example, or shoulder pain or neck pain. Does this actually cause a medication overuse headache? There's more of a bigger association if someone has a pre-existing headache disorder or a migraine history, but honestly, this isn't well studied for the other types of pain. Opioids have been studied in terms of potentially causing some rebound chronic pain and changing the pain pathophysiology, but not as much for the analgesics or the over-the-counter analgesic meds. So, what do we do, especially as physicians and practitioners, is to get off the analgesic meds right away. So, if they're taking triptans more than 10 times a month, we get them off the triptans. So, it's like a detox. If they're taking opioids, definitely get them off the opioids. If they're on ibuprofen every day, we get them off the ibuprofen. So, what do we do? Because when they go off of it, they're going to get a rebound headache. It's almost like going off caffeine. And by the way, caffeine can do the same thing as well. So that's why we recommend decreasing caffeine when someone has a chronic headache disorder. Um, these medication can be withdrawn for the most part pretty easily, especially for the over-the-counter analgesics, as long as we also have a little bit of a bridge. Now, the literature shows some bridges, meaning like giving something until you get over that medication overuse headache. So these are like greater occipital nerve blocks or trigger point injections or even IV medications such as IV dihydroergotamine or IV DHE in the hospital, steroids, which don't have much great evidence, and then other medication preventives. But again, the medication preventives can take several months to work, as discussed in my previous migraine preventive video. So what I do is I provide something called meloxicam or a prolonged NSAID that lasts more than 12 hours. So meloxicam is a 24-hour medication, and when given at the 7.5 milligram dose per day, typically in the morning, because the first 12 hours work better than the last 12 hours, this actually provides some analgesic and some pain relief, but also it doesn't cause as much medication overuse compared to the shorter acting over-the-counter analgesics. The other benefit of meloxicam is that the 7.5 milligram dose is more ubiquitous for the COX-1 and COX-2 enzymes compared to ibuprofen, which can really latch on to those enzymes that cause the cardiovascular risk, the kidney issues, and the GI side effects. So meloxicam, the 7.5 milligram dose, tends not to have as much of the bad side effects compared to the meloxicam 15 milligram dose, where it can cause more of the cardiovascular risk, more of the GI side effects like gastritis and ulcers, and kidney function issues. So usually I'll start meloxicam for about 1 to 2 months daily, get them off all over-the-counter analgesics. I'll get them off all triptans, ergotamines. I'll get them off if they are on opioids, which none of my patients are on. As well as barbiturates. So I get them off all of that and just do meloxicam. And maybe within a month, they can do occasional acetaminophen or occasional naproxen. I tend to like naproxen more as a analgesic medication or in my headache cocktail with an antiemetic because it lasts for 12 hours. So the shorter acting, the 4 to 6 hour acting analgesics tend to cause worsening rebound headaches or medication overuse headache compared to the longer acting, like the 12-hour meds or this meloxicam, which is a 24-hour medication. Caveat with the meloxicam is making sure that we are avoiding any drug interactions just because a lot of people who are on uh, migraine medicine or headache medicine or who have chronic pain can also be on SSRIs and SNRIs, and when combined with meloxicam can actually increase the bleeding risk or even side effects, which sometimes people can actually have worse anxiety or worse depression when they're taking both meloxicam and SSRIs. Okay, so the challenges to the medication overuse headache when starting therapy. So, not only do we start meloxicam and get rid of the over-the-counter analgesics or the triptans or the abortive medications that they're overusing, we also start a migraine preventive. Now, the migraine preventives can take up to 8 to 12 weeks to become effective, but in my migraine supplement preventive video, when I use all three of the migraine supplements, if tolerated, the magnesium, the riboflavin, which is vitamin B2, and CoQ10, I tend to see faster benefit, faster efficacy with all three combined compared to one each. So usually I can get them better within 4 to 6 weeks compared to 8 to 12 weeks when I combine all three, as long as it's affordable for the families. So that is sort of in a nutshell of the medication overuse headache. If you are interested in learning more, you can go over to dranamd.com and feel free to browse through the courses over there. I've got pediatric headache course, I've got a adult headache course, and then coming soon is the integrative pain fellowship, which will encompass all headache and pain. All right. Well, either I'll see you over on the podcast or the next video. Take care.